Morning, everyone. IAPS. It is auspicious in mood. I kindly IAPS and Dr. And the organizing.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Now I would IAPS 25 come on this stage and
Nath, Nerd, welcome Dr. Kumar Biswas, President IAPS, Dr. B Agarwal, Secretary General, all the distinguished member, delegates coming all over India and abroad to the first annual conference of Odisha Chapter. So in the land of Lord Jagannath. So I am welcoming everybody. This abode of Lord Jagannath, one of the Char Dham. So I expect a good show from the organizing side, and also we are working very hard. Our team, our all the faculty, all the residents, with the help of Central IPS, who are working day and night to make it memorable. So I again welcome. Thank you. Thank you, Lord Jagan.
Now we'll start with the first session of the day, that is annual function of Odisha chapter and felicitation of senior members of Odisha. I would like to call upon stage. I would like to call upon stage chairpersons, Dr. Manoj Kumar Mohanty, Dr. Tripathy, and Dr. Prakash. Now I would like to call upon the stage our first speaker for today, Dr. P.K. Jena, presenting pediatric surgery.
Jai Jagannath. Nothing moves without the wish, Jai Jagannath. You have come to the Puri is not by chance, it's desired. Somebody desired that you should come and have darshan. You may not go to the temple, but you have come to Puri. That is more than enough. And there is a Swargadar here. And people say that there is a roads or there is a stair from that place to the Swarg. Yes, so that is known as Swargadar. It's a very, very auspicious place and have been destined to visit Jagannath. That is one of the एक बार अगर जगन्नाथ का दर्शन हो जाएगा, like yes, believe much more Jagannath. Everything is depends on him. So once again, we welcome you to the land of Jagannath. Jai Jagannath. I have been assigned to speak pediatric surgery in Odisha, past, present, and you can see Odisha, formerly known was Orissa. Now we have changed the spelling everywhere. The name changed, but we have not changed the name. We have changed the spelling. So it looks like it appears as if we are speaking in not in English. It is in Odisha in Odia. Okay, Bhubaneswar is the capital city. Everybody. Odisha is known for rich cultural heritage, including ancient temples, classical dance forms, and traditional music. Odisha has a diverse landscape with forests, rivers, beaches, and you think of anything. People used to say that anything in the world is also there in India, and anything in India will find all the types of climates, everything in Odisha. So Odisha is a miniature India. State celebrates various festivals, including famous Rath Yatra, Makar Sankranti, and Kartika Purnima. Yesterday was the Kartika Purnima, where Odisha people used to go in maritime commercial activity. We usually celebrate in a big way. Odisha's cuisine is also very Odisha's cuisine is also very known for its spiciness, simplicity. Dishes like bharta. Bharta can be any baingan bharta, aloo bharta, so many things are there. Dalma, that is a mixed vegetable of all. Chena podo, and everybody knows rasagolla. So before, so I have divided the history of Odisha, past, present, and future. And in my most of my speak, you will find that his past and present is all amalgamated. So I have to conveniently describe how we have there in Odisha. So we'll describe up to 2007 and after 2007 and private sector. So now we'll go to Sri Ramchandra Bhanjo Medical College, Cuttack. Okay. Without this, we cannot start. To Cuttack, the Millennium City. It started in 2000, around 10th century. The city was still there. It started around 10th century. And thereafter, now 1500 years old, that city. So that city has shown the Cuttack, the word comes from a, means it is a cantonment or fort. It It is there since Maratha rule prospered as a center of trade and commerce between Marathas, British, and the Muslims rulers of Bengal. Education, I will go into little detail after that. Okay. Sri Ramchandra Manja Medical College is started as a center, first aid center. Those people who used to come to Puri through Cuttack, during that place where the SCB Medical is situated, it started as a first aid box. Now it has grown into a big medical college, and it was inaugurated in 1844. The Odisha Medical School started in 1875 and became a full medical college in 1944. So they are the birth of medical college. So these are the people who contributed. So that is one is Sisu Bhavan. One is SCB Medical College, where this Department of Pediatric Surgery is not there. It is there in another building, 5 kilometers away, and that is known as Sisu Bhavan. Sisu Bhavan is a popular name, but the original name is Sardar Vallabhbhai Patel Postgraduate Institute of Pediatrics. So you can see this is a picturesque place. Cuttack, never from all sides. You can see the mighty Mahanadi dividing into Mahanadi proper and Kathojadi again dividing into two rivers. So this is the Cuttack city. You can see the Cuttack city here. Pointer. So this is the Sardar. So this is this Sardar Vallabhbhai Patel Institute of Pediatrics, where this our place is there, and this is Cuttack railway station. Find the medical college and both the mighty Mahanadi river and Kathojadi. It divides into Cuttack city is all surrounded by the rivers. So, although the Postgraduate Institute of Pediatrics is a part of SCB Medical College, it has got a different history as compared to the college. Sisuavan is situated in the banks of river Kathojodi, that is in the fort-like building, which was the center of administration since 1568 for the Marathas, for the Mughals, and subsequently the British. With independence, it witnessed the important event of instrument accession by which several princely states were amalgamated with Odisha in the august presence of Sardar Vallabhbhai Patel. That's why it carries the name of Sardar Vallabhbhai Patel. The building continued to be the Raj Bhavan after independence till 1961, and thereafter the then governor, donated that uh, Sishu Bhavan to make a children's hospital, and the Raj Bhavan there was shifted to Bhubaneswar. And during 1966, the state government took over that building and started the medical college, started the Institute of Pediatrics. The institute started with a bed strength of 200 in that time. Now it is 846 in 2025. So few photographs that you can see. So Sardar Vallabhbhai Patel Institute, you can see how much of the collection is there. And this is one of the old institute. This is old. This is another old gate. This is number one gate. There is second gate in 2007 and 2025. Another gate is with there. So this is, you can see that this was the English type of gates. And you can see this is the residence. This was the office of that administration, whoever was there, Marathas and all these things. And this was the residence. So this residence is Salya Chikitsa Ward. This is the pediatric surgery ward before 2007. Okay, this is inside. You can see the operation theatre. So this was the photograph in 1947, the governor's house, 47. And this is later. So the Department of Pediatric Surgery started in the institute in the year 1966. 66, 65 is a year where most of the pediatric surgery departments started in different medical colleges all over India. The department was initially managed by general surgeons with interest in pediatric surgery. Dr. Guru Prasad Mohanty or Bhavani Shankar Das, Dr. Lambodar Pati was the head of the department, and Dr. S. Saifullah, incidentally, is the first MCS from Chandigarh, first MCS student from Chandigarh. So he joined the department in 1969. Subsequently, many pediatric surgeons trained in different parts of the country, like BP Das, Parida, Dr. H.K. Mohanty, and all these people joined and made a lot of contribution to the institute. So the Department of Pediatric Surgery, super specialty degree courses in pediatric surgery started in August 2007 with one seat. And fortunately, Dr. Akash was the first MCA student from that place. At present, the number of seats have increased to 6 per year, and many students are being trained for the super specialty degree course. The bed strength of general pediatric surgery was 20 in 1966, now 60 with additional newborn surgical beds of 12. The average footfall is around 80. Departments shall be equipped further with new instrument equipment like variety of endoscopes, laparoscopies, which are being added along with the increase in bed strength from 80 to 46. In addition to all the instrument equipment already is a part of the armamentarium. So MCS pediatric series started in 2007. In 2007 is one seat. 2010 is two seats. 2017 is uh, 6 seats. So I think Dr. H.K. Mahathir will be very much pleased to see his fruit. So he was the pioneer in starting MCS course in Shisu Bhavan. So in 2007, another new building was added with the help of the Japan government, the Advanced Care and Research Center. So there, what happened? Total the OPD building was newly constructed. Radiology, PICU, NICU, and all these things were services were inducted. But for pediatric surgery, it is a total different. New pediatric surgery ward was new OT complex. Everything was in addition to that old that I have already shown. This is These are the few of the photographs. So you can see the Kambasi chart, Dr. Lambodar Pati, 1966. So this is the pediatric surgery ward, and this is the all ICU and ICU. In 2024, Sishu 1 got a new building, and the total bed strength between 48, 846, with addition of all types of new instrument equipment, which are gradually being procured there. So these are the new buildings, OPD block, and this is the new gate. This is the third gate. This is the hostel and the pediatric surgery ward, pediatric surgery OPD. So MKCG medical. So that is about SCB. The second, or not exactly second, this is the third medical college in Odisha, started in 61, became a full-fledged hospital 73, and first one is other, which was there, the second one, but pediatric surgery department opened only late. So this is in the sea coast. You can see this. Parampur is here, Parampur, and I think the Tika lakes are here. Puri, you are standing there. Parampur and Chhatrapur, I think Gopalpur, you can Gopalpur. So, so this is a rare video that I collected sometime 2005 and 6, recorded by me. See the old how it was there. Okay. Now there is no space, and Dr. Manas is there in Parampur, and there is no space, and all the building, all the space have been converted into building. I will show you also the. So this is the statue of the Maharaja Krishnachandra Gajapati, on whose name the medical college have been named. So this is the indoor building, which was the only indoor building now. Now there is no space, a lot of buildings. So how was our Department of Pediatric Surgery? So everybody will be pleased, amused to see this recording where they worked long time back. This is the Department of Pediatric Surgery. Okay, this is the duty room that we all worked there, and this is the pediatric surgery neonatal surgical ward, post-operative. So Professor B.P. Das, Balabhadra Prasad Das, was the second person to do MCS from Chandigarh, and he joined as Department of General Surgery when Pediatric Surgery Department was started. But in 72, he started the Department of Pediatric Surgery in Parampur. Joined as Assistant Professor in Pediatric Surgery, later in Sishu. So this is MKCG Medical College, and so many super specialty departments are there. And we have got so many DM and MCS seats also, but pediatric surgery is going to open very soon. Then just skip. So these are the 2009 we got recognized, and we celebrate. We first conference was done there, and this is the organizing the annual high tech medical college is there in the private. This is Sikha and Anusandhan University. A lot of work has been done. So these are in the private sector. And second campus, AIMS Bhubaneswar, has changed the total scenario in Odisha. And they are very happy to do the conferences. KIMS Medical College is another place. Okay. And in Burla, there is a department, pediatric surgery, which has started just now in 2023. And two people are there. And these are the private sector, Dr. P.C. Das in Baleshwar and Dr. P.N. Misro in Bhubaneswar. And future is the best way to predict the future. Get it? Best prediction. Okay, and CB Medical College, this is a one example. We are going to have 6,000 beds with a lot many facilities. Similar advancement in technology infrastructure is happening in the private sector too. And pediatric surgery in Odisha. So all these things are. So this you come here. So these things all future. And this last picture, the last picture. You can. I think everybody is familiar with this. But the latest thing is this is somewhere else and this is elsewhere. I think good. So this is something happened. We have already done in Odisha in second case, but in adult. They're also in at par with. Thank you very much.
Our next speaker for the day is Dr. Alok Kumar Sahoo, who's additional professor in the Department of Anesthesia, AIMS Bhubaneswar.
Good morning, all. Jai Jagannath. At the outset, I am being honored to be here. Thanks for an organizer for inviting me. Thanks, dear Manoj. Santosh. So here we have an interesting topic. Okay. So, for the present, future, and past of pediatric surgery, we'll come to the induction phase of pediatric. One of the important uh, aspect of the pediatric surgery. Why I am saying so? Because nearly 42 to 50% of cancellation in pediatric surgery is because of URI. So how to go through it? Why we cancel? What to do? What is the current recommendation? This is how we will go for. So I start with a case. This is a 3-year-old child. History of mild rhinorrhea and cough. Posted for elective hernia surgery. It is he has a currently no fever, cough, rhinorrhea, and surgery procedure. So during extubation, patient was intubated, and during extubation there is desaturation, bradycardia, and was diagnosed as laryngospasm. Patient is desaturated, so need some maneuver, pressure ventilation, and deepening of anesthesia. Monitored in ICU and post-operative care unit, and later on. So this is an day-to-day life of pediatric surgery and anesthesia. This happens many times. So this is why this happens and what should surgery be postponed and was it preventable? That is the question. Can we prevent this? Should we not take the patient for surgery or what are the future? So why it matters? URTI is the first cause of elective surgery cancellation in extremely common in less than 5-year-old child, 6 to 8 episodes per year. Up to 45% of kids present with current or past URI and known to have increase in perioperative respiratory adverse event by 2 to 7 times and up to 11 times if endotracheal tube is in. You see the graph. Patient has URI. There is increased in risk of perioperative respiratory adverse effect, PRAE. So PRAE occurs in 15 to 50% of child under general anesthesia. So in kid, you have to give general anesthesia because you can't just sedate them and give a regional anesthesia. They will not tolerate regional anesthesia at all alone. So you have to give sedation and general anesthesia before giving regional anesthesia. So why we cancel the case? What is the perioperative risk of why this? What is the PRAE? Is laryngospasm, bronchospasm, leads to desaturation and prolonged oxygen therapy and unplanned ICU admission. These all constitute post perioperative respiratory adverse event. What are the risk factor? Risk factor are prematurity. That is, if child is less than 37 weeks, reactive airway disease like asthma, there is childhood asthma, parental passive smoking. It is one of the important risk factor right now. It is the odds ratio of 5 times. That is, if parents are smoking, there is 5 times chance respiratory adversity and a respiratory comorbidity. That also increase your perioperative respiratory 6 times. And parents believe that what is the parental or the patient factor? Patient factors are parents believe that child has cold, copious secretion, nasal congestion, sputum production, and URI less than 4. What are the surgery factor? There is an airway or oral cavity surgery, and the anesthesia factor is direct laryngoscopy of endotracheal tube versus trachletic airway device, or absence of pediatric anesthesia is also one of the risk factor in the perioperative respiratory adverse event. So, what is the pathophysiology? URI causes airway hyperactivity, mucous edema, and increase leads to sensitization of airway to anesthetic. That leads to activation of smooth and contraction in that causes for bronchos. Neuroamynide produced by some virus inhibit M2 receptor with acetylcholine lead to the risk peak at 1 to 3 days after onset and persists after 6 weeks. So this is a pre-operative risk assessment score, that is cold score, that can be used to assess the tool. A score greater than 10 is there is high risk of perioperative respiratory adverse effect. So this is how the evidence are. There is a cold score greater than 10 increase the odds risk 7 times, 4 times. So comorbidity and 3 times. That is what I have told. So what is the surgeon's perspective? Why to fix it? Why they want to fix it? There is 8 episode URI in a year. That so the hyperactive airway persists to 6 weeks. That leads to 8 into, if you multiply it, it is 32 to 48 week. Patients are sensitive to have an perioperative respiratory airway adverse event. So there is no time. Risk stays throughout the year. There is very small time window to have a surgery. If you cancel always. So, so elective surgery are often time sensitive. Delays can lead to lung symptoms, dental anxiety, physical challenge, and sometimes worsening of condition. Some surgery you can delay. So there is a surgeon perspective throughout the year. The risk stays throughout the year for young kid. So what to do? So it is an tug of war between disease and doctors, or you can say plan and will don't plan. But the ideal is the we have an combined decision making. So what is the combined decision making? How to fix this thing? So if child presenting for elective surgery with URI, mild URI with mild nasal discharge, dry cough, it, and consider anesthetic factor that mitigates PRAE, that is preoperative optimization. So if moderate, there is significant high or it is individualized. May cancel if age is less than 1 year, prematurity, passive smoke, high risk airway surgery, and severe airway URI, you always cancel. If I summarize this solution, the mild URI, so only runny nose, child is active afebrile, then and long surgery is minor. There is an and anesthesia. And if you are using a supraglottic airway device like laryngeal mask or ISL, then you will go for the surgery. And postpone if fever, the systemic or respiratory sign is airway surgery planned. High risk patient that is less than especially X prime and history of reactive airway disease. So in this scenario, cancel. So the collaborative protocol is our preoperative hydration, the regional anesthesia if or by supra use better than endotracheal decon. But I think we are very used to this, but it will not work if child is below 6 above 6. IV propofol or IV induction is better than opening up airways. Clear plan that tackle the very upper like laryngoscopy, bronchoscopy. So there is a shared decision making. Surgeons should be taken into it. Balancing risk and document and a rationale all clearly. You have to document it. You have to inform the patient there is a high chance can happen, but we will take care of it. So this is how things can be done. So our pediatric surgeons are very friendly with us. I think it's a very rare combination. We have a discussion and with mild respiratory condition, usually take because we have a lot of gadget and ultrasound device to give regional anesthesia. So we give many times supraglottic airway device and various type of block, and we do it regularly. So URA dilemma is a gray area. It is always not black and white. Most cases fall into moderate risk category. Final decision is spent based on experience of nature of surgery and the family context with judicious assessment, teamwork, and evidence-based protocol while avoiding unnecessary delay. Thank you very much. Any question? No, sir. Exactly, it is not like that. It is hyperreactive airway persists 4 to 6 weeks. So you have to wait or not. You have to wait. It depends upon the type of surgery, nature of disease or patient, the risk factor, and nature of surgery. Let it is an airway surgery. You are doing an airway surgery, tonsillectomy. You are doing an bronchial surgery. Then you have to wait. And if patient is low risk surgery, like you are not fiddling with airway, and you have an experienced anesthetist, and patient is let there is no other risk factor, you can go for it. It is not contraindicated right now because if you consider 6 weeks, then it is throughout the year. It is always there. Sir, the objective way I have shown that risk factors. So if you and there is a cold score is there. So you can use that cold score. So that is very objective way. If score is greater than 10 and it is greater than 10, even it is also been seen that a score greater than 10 is not an absolute contraindication for surgery. You have to see the nature of surgery again come to that aspect. Let child is parents having smoking or child having asthma, child having snoring like patient has like OSA, then you have to taken into consideration to expertise and also prepare for PRAE. You have to prepare for laryngoscopy. It is not absolutely safe that that will not happen. It may happen, but you have to take the precautions.
Thank you.
Thank you, sir.
Thank you, sir, for sharing this valuable knowledge with us. Our next speaker for this session is Dr. Prakash Agarwal. Please, Dr.
Namaskar, honored seniors, dear colleagues, young surgeons, and friends. It's a privilege to stand before you today, and I consider it myself as very lucky to be the first orator for the Odisha chapter of pediatric surgery. I thank the organizers, Manoj Bhai, Akash, Subrat, and Vikash for this opportunity, and all the seniors for their blessings. I was born and trained in Odisha, and those formative years shaped not my hands, but also my heart. Today I live and practice in Chennai, yet every patient, every lesson, every aspiration carries a thread back to Odisha. That thread is why this topic, nurturing the next generation pediatric surgeons in India. And it matters so deeply to me, and that is why it matters to all of us. Because before I dwell on the topic of nurturing the future pediatric surgeons of India, I would like to assess ourselves where we stand today in India. If you compare India with the other advanced countries, we see that in India, we are in a very strong position with regards to all the clinical domains we have. But where there are few gray areas are like the infrastructure, which we don't have much of. The main thing which I will be discussing today is the manpower, which is the future pediatric surgeons we are going to groom, and the follow-up systems. Follow-up system has been very bad in India. We have a better follow-up like we have in West. So these are the three gray areas out of which we'll dwell totally on manpower is the future pediatric surgeon we have planned. So the clinical domains that I'm talking about, which we do very well in India, is the clinical skill and the operative expertise. Phenomenal, excellent. Some centers do so much of complex neonatal work that we are recognized worldwide for our clinical skill. Then coming to the workload and case exposure, our workload in some of the centers is so high that surgeons have unmatched quality. They do phenomenal work and they have a wide spectrum of congenital anomalies that which we deal compared to the West. Our adaptability and innovation, we are at par with any other country in the world. We have a special strong influence of the adaptability nature of Indian surgeons compared to our Western surgeons. And if you talk about cost effectiveness, we are a very cost effective society. And what we have something called jugaad. We know how to do jugaad in each and every aspect of our surgery, how to cut cost and how to make the surgery more effective. If you compare our MCH curriculum compared to the West, we are a very good, robust MCH program in India running now. And the DNB program is also equally great compared to MCH program, and training program is at par with any other Western country. If you talk about cost and accessibility of surgery, we all know that we are very much cost effective compared to our Western counterpart. Now, we all know that India is becoming a world leader. The last 10 years, it has become a great economical, great country, as well as when it comes to our manpower, we are a 1.4 billion population, out of which 450 million are only pediatric population. So we know that we are going to treat this pediatric population at some stage or the other. That is why you see the map on the right. That shows the training center all over India. It's been devised by Vikesh Agarwal, which if you click on that, you can have the map and that will show you the center. You can see it's clicked on the SCB Medical College, which has MCH seats, 6 in number. And that is how there are about 54 or 55 centers all over India which are imparting MCH pediatric surgery, and they all have a robust program which is going very strong. The other thing I can tell proudly is that you see the total estimate pediatric surgeons trained in India now working abroad are about 700 to 950. Those who are trained in India, but they are working abroad. And few of them are my friends. I know that they are in a good leadership position. So what are we looking at the future? To train good pediatric surgeons can hold leadership positions in the future. So this is the biggest achievement we have got in India in the last 14 to 15 years. Now, if everything is good, then what is the problem? In management parlance, we call it a SWOT analysis. You know your strengths. At the same time, you should know your weakness, you should know your threats also. Because you are going to train a future pediatric surgeon, you should know what are the problems he may face in the future, so you make him ready for that. One thing we realize that in India we have uneven access to training. In some centers, the training may be very good. The centers, it may not be as good as the center. So there is always variable quality in the training that we give. Burnout is one more word that is going on now, and somebody is doing a research. Burnout and toxicity is being talked about now, which was not there in our times. Excessive workload on the students. So we should see how we can negate it and make their life much more simpler. And the thing which I am going to talk today is the structured and the shortage of manpower is to mentor the student. So structured mentorship is what is lacking in most of our curriculum. The other threats that they will face is the lack of job, for which they go to foreign countries, start working abroad. Most of the pediatric surgeons concentrating in cities and very less into rural areas. So we should know how they should cope up with the and overlap of with other specialties. We know very well that for hypospadias, how we fight with our urology colleagues. Similarly, other procedures, there are gray areas, fight with plastic surgeons. So how to overcome those problems and the resource inequality. If somebody is working in a government sector and somebody is working in a private sector, definitely the pay scale, the remuneration, everything differs. So what we can do to make these things uh, equalize for both the sectors. Now, these major gaps in the clinical domain are all related to standardization of the care because and there is wide heterogeneity in the standardization of care. We feel that the PG who is trained is not trained properly. Then the other area of problem is neonatal care, neonatal surgery. Some centers will have enough neonatal workload, some centers do not have any neonatal workload. That is also one area of concern. Similarly, if you compare minimally invasive surgery to robotic surgery, some centers in India are doing very good lab surgery and robotic surgery where the centers are not doing it. Research, similarly, a lot of centers are there who are publishing good materials, good research work is going on, but some centers are not doing any research at all. All these things we should take into consideration when we are teaching our postgraduate student and see that they have outlook which they can match with international quality. So how to build this gap is by nurturing. What nurturing means? Nurturing doesn't mean that you hold the hand and teach the person. The holistic way of teaching somebody a technique or making them more adaptable to the ecosystem. It's actually a holistic way of looking at a student where you can train him, you can guide him, you can mentor him, and see that he becomes a successful and great surgeon. So these are the 7 points which I have come with. Then if you look at these 7 points, you can train and see that most of the problems which we have discussed can be taken. One is the structured training, which most of our universities, they give a proper curriculum. Okay, this is the curriculum we should follow. And most of the universities do follow it. But what is required is to make them good in core competencies. See that they attend fellowship programs. see that every trainee achieves some amount of surgical training when they are working with the cognitive skills, the communication milestones. These are all achieved by the surgeon who is getting trained under you. High quality mentorship. That is what I meant. That when we are training, we should assign them a proper mentor that they tomorrow when they go out, they can take you as their uh, mentor and they can tell, okay, I was trained under this person. He was my role model. So you should become role model for your PG students. When you take about simulation and hands-on exposure, that also should be good. They should get enough hands-on exposure. And the research material and that thinking which you should bring in them should get into them the research orientation and the mindset. And you should take care of their wellness. They should not be burnt out. They should have equal access to all the tertiary care centers as well as they can manage a rural health center. That should be the level of training. And we should train them in such a way that they become future leaders. We have 20. So what are the concrete steps that we have to take to fill up these gaps? We have to create mentorship circles. When the student is coming to you, he should find a good mentor. It can be in the institute, it can be outside the institute. And I can tell you with conviction that IAPS has already started this mentorship circle. You can see the screen that we have a IAPS G community where there is a mentorship circle. Students who have problems are discussing their problems, coming out with what books to read, how to deal with this case. Any problem they are discussing in this group, and that is how it should be. You should have a series of visiting faculties to your colleges or to your institute. Can in between come, give lectures, show cases, do workshops, so that their knowledge and skill also improves. At the same time, you should have a confidential peer group where the student can come and confide on you what are the problems he's facing, how to come out of it, maybe personal, maybe academic. So he should have the confidence in his peer to let out his feelings. Rural pilotship project is going on in many of the hospitals in many of the states in the country where students are posted in the rural health centers so that they know how to treat a patient in the rural setting as well as the medical college setup. The two different avenues where they should be properly trained. They should come out, be expert in both the areas. And similarly, we should have career pathway sessions. When the students are there, they should know what to do after this. They should not be left in the lurch, doing what not to do what after they pass out. So all these things we have to keep in mind when we are teaching them and training them. So here are a few examples which I know that most of the institutes in India are doing. These are a few examples. The first picture you can see how AIMS had created a workshop on hypospadias. Definitely the students would have achieved a lot of knowledge about that. Then we have a lot of workshop on laparoscopy. We must. PSC always does a workshop to showcase all rare cases and common cases for pediatric surgery PG. And at the PSC conference, we try to have the pro trainer sessions also so that people have hands-on training. This is one picture which I remember most. My mentor, Dr. Hawktan, was from Australia, is no more. He trained me, and I am training Apurva, who has become an expert laparoscopist now. That is how the things have to percolate from your mentor to the next to the next. And we intermittently do Potacath training at Ramachandra, where we have a group of 4 to 5 people and teach them Potacath when they are lacking in some skills or knowledge. So similarly, I'm sure a lot of other institutes are doing it, and we keep on doing it so that it percolates down to the PG, to the residents, to the fellowship, where we are trying to make them into future pediatric surgeons. Now, when we tell this, it doesn't have to go into air. Every person, every institute, every society has to take some or the other responsibility. What it can be, as a faculty, you should allocate yourself to the protected mentoring time for. It's not that you just tell in pen and paper. You should be a coach, you should advise him, be a proper teacher, and you have to guide him. Similarly, your senior residents in the department can become their consultants, can manage them, can be their counselor and be a role model for them to futuristic. Hospitals, what the hospitals can do, they can provide simulation lab where you can see such a lab is existing, where you can put central lines, put the coastal drains, test drains, do thoracotomy, and learn lot of things on simulation. Yeah, everything may not be possible to learn on patients. So you have to have simulation labs. You are coming in a big way. And what the societies can do. I was seeing through a beautiful website of Odisha chapter. They can become mentors for a lot of students by matching such programs. They can announce when is the next workshop, what are the list of opportunities. Similar thing is going in the IAPS group. I think Odisha also can emulate that and inform their PGs what workshop is going on where, what are the training programs going, what are the matching programs going on so that they can take advantage of such situation. Now, when I say all these things, why does it matter? Matters because how you have trained your postgraduate student, how you have trained them, that matters a lot. This is example from my WhatsApp chat, how my friends, my colleagues keep on asking me what to do. And if you don't train them or if you don't guide them properly, this will. One of my colleagues in down south Tirunelveli sends me this X-ray saying, what is happening? I can't understand. I replied to him, this is malrotation. You have to do immediate laparotomy. Then he tells, can I do a contrast study? Okay, go ahead, do upper GI contrast. He does it the next day morning. Okay, now you operate. Why the contrast is not going down? And the third day he operates, he found a gangrenous midgut volvulus. So if you are aware of such a thing, you will not do this delay, and this problem should not happen. The poor patient. Another colleague of mine in Karnataka sends me this picture of a body without hypospadias. He's never seen one. So he's asking, there is a partial phimosis, glance is still. I am not trying to degrade him, but what I'm telling is, if you are aware, if you are trying to mentor somebody, tell him, you listen, and things will go wrong, right at the. This is one more success story where one of our PGs is working in Salem, very fancy for foreign body removal. And every week he's removing almost 2 foreign bodies from children. And now he's become a big fan of the people around Salem, so that he's doing a fantastic job there. So there are both plus and minus, which you have to keep in mind. How you train people and how you guide them is very important. What we have started in IAPS, this is whatever I've been talking till now. You see that in IAPS, every conference, we try to see that one or the other topic is talking about this mentorship. You can see the topics, challenge faced by pediatric surgery, challenges and remedies. These are all real-time lectures which have been taken in IAPS conference and is available online. So you can always access. Post MCH mentored learning in mass and pediatric Europe. Appropriate research environment. These are all real-time lectures which have been taken, and I think a lot of people are getting benefited by it also. So it is upon us how we take it and move forward. Now robotic mentoring has gone to a different level with the advancement of technology. Dr. Jena was talking about this, where somebody is sitting in Gurgaon and operating on a pediatric pyeloplasty at Hyderabad. So it is done by an adult surgeon. Not encourage it, but I'm talking about technology, how it has gone ahead, mentorship. And similar case has happened in our own city of Cuttack, where tele-robotics has happened. That is what Dr. Jena was talking. So that is how mentorship should be, and it should always adapt to the new technology and take it to the future. After doing all these things, how do you know whatever we are talking and we are doing is working or not? So you should always audit yourself. When we do the auditing, we measure the success by checking how many competency training program he has undergone. We should have a checkbook. We should have a logbook where we can mention everything. What are his research output? How much paper he has presented? How much research he has done? What are the workshop he has attended? Whether he has attended the workshop lagging. And if there are placement and retention risk which is going to be taken care of, whether he is in a good position, whether he can be placed in a correct place, things we should take care of them. And after all, we should always take their feedback. What is their wellness survey? Did they like it? Did they have any problem? or what was the problem. We should always take a feedback and work on it and see that we make their future much more. If you ask what is my take on nurturing is not intentional. It doesn't come by default. It needs time and commitment, and the mindset has to change from I teach where I can to we systemically develop. We have to develop together. Let us build training that honors our roots in Odisha, leverage expertise across India, and produce pediatric surgeons who are technologically excellent, humane, and ready to serve every child who needs them. So for every child we save, a family keeps hope. We should always remember. And for every pediatric surgeon we nurture, thousands of future will change. Let us be the gardeners of that future, careful patience and relentless. I would like to end my talk with a shairi always given by my mentor. खुदी को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से पूछे बता तेरी रजा क्या है. धन्यवाद. जय जगन्नाथ.
We are very happy that you had a very elaborate view about the national scenario and pediatric surgery in particular. My question is, what is your view regarding the role of our association? Uh, two, three things. One is about popularization of pediatric surgery in undergraduate levels. When we were taking, that time about 10, 20 years back, we were taking undergraduate classes, particularly pediatric surgery classes were being given from general surgery side. Now it is stopped. Nobody is it is medical council didn't allow. Next is general surgery training. The MS people, they don't come to pediatric surgery. If at all they come, they just come for attendance sake. And next thing is, what is our association doing for basic surgery, basic pediatric surgery in remote areas? India is a big country, and particularly pediatric surgery patient, when they travel 400, 500 kilometers to Cuttack, Bhubaneswar, particularly these area, by that time they are not fit for surgery. So, what is your view regarding all these aspects? Which you should know, you should tell us.
Postings in medical college, surgery PGs are posted in our department. It is our work to see that they get some chance to operate or to assist in the cases. We also sometimes neglect them. Then they will never develop an interest. It is our work to give them some work and see that they assist in all the cases. They write the case sheets. They present in some conferences. Then only they will develop the interest in that topic. Otherwise, we just don't take care of them. We neglect them. They will also feel neglected. The other thing you told is how to make pediatric surgery felt all across India, even in rural areas. So the Pediatric Surgery Association is trying to approach the government that every district in India should have a pediatric surgeon. If that happens, which is already happening in Maharashtra, happening in Tamil Nadu, some states it's already there. Every district has a pediatric surgeon. If that happens, then pediatric patients need not travel far off long to different centers for their treatment. They can be handled at the district level.
Thank you, sir, for
Thank
this
you.
thoughtful and insight-provoking presentation. I would request Dr. Manoj Kumar Mohanty and Dr. B Tripathy felicitate Dr. Prakash Agarwal for his oration of IAPS Chapter of Odisha. Next, I would like to call upon the state speakers for this session to be felicitated by our respected chairpersons. Dr. P.K. Jena, Dr. Alok Kumar Sahoo, with great pride and joy, let us now begin the felicitation ceremony to honor those who have made outstanding contributions to the field of pediatric surgery in state of Odisha. I would like to call upon the stage Dr. Sumitra Kumar Biswas, President IAPS, Dr. Vikesh Agarwal, Secretary General IAPS, Dr. Manoj Kumar Mohanty, Organizing Chairman of IAPS Con 2025, and Dr. Bikasa B Tripathy, Organizing Secretary of IAPS Con 2025. I would like to call upon stage Dr. H.K. Mohanty.
It is our honor and privilege to felicitate Professor Dr. Mohanty, an eminent pediatric surgeon, visionary, academician, and inspiring mentor. Dr. Mohanty, a postgraduate of PGIMR Chandigarh, has had a distinguished career spanning more than 4 decades. He has served as professor and medical superintendent of SBP Postgraduate Institute of Pediatrics, SU Medical College, Cuttack, the largest children's hospital in eastern India, and later as professor of pediatric surgery at IMS and SOM Hospital, Bhubaneswar. He played a pioneering role in establishing the MCH course in pediatric surgery at SCU Medical College in 2007, a milestone later recognized by the Medical Council of India. Under his mentorship, numerous students have risen to become leading surgeons and professors in India and abroad. Dr. Mohanty is the founder chairman of Odisha Chapter of Indian Association of Pediatric Surgeons. He had the distinction of hosting the 39th annual conference of IAPS at Bhubaneswar in 2013 as the organizing chairman. With remarkable skill and courage, he performed the first successful conjoined twin omphalophagus separation in Odisha in 2003, a historic surgical feat. He has to his credit 25 national and international publications, served as examiner and assessor to the prestigious institutions including PGIMR and Guwahati Medical College, and represented India as a WHO fellow at Westmead Children's Hospital, Sydney. A surgeon par excellence, a teacher beyond compare, and a visionary leader, Professor H.K. Mohanty has dedicated his life to advancing pediatric surgery and nurturing generations of young surgeons. IAPS Odisha chapter salutes his immense contribution to medical education, unwavering dedication to patient care, and his lifelong pursuit for excellence.
Next, I would like to, Dr. Niranjan Parida was not able to attend today's session. I would request Dr. Santosh Mahalik to receive on his behalf.
Professor Dr. Niranjan Parida is a stalwart in the field of pediatric and neonatal surgery, whose remarkable career spans over 4.5 decades of dedicated service, academic excellence, and compassionate patient care. Dr. Parida completed his MBBS and MS in general surgery from SCU Medical College, Cuttack, and went on to earn his MCH in pediatric surgery from the prestigious Postgraduate Institute of Medical Education and Research, Chandigarh, an achievement that marked the beginning of a lifetime devoted to children's surgical care. An outstanding teacher and mentor, he has inspired generations of pediatric surgeons and contributed extensively to medical education. Dr. Porida's exemplary service has been recognized by the Association of Surgeons of India, Odisha State Chapter, which is honoring him which has honored him in 2020 for the outstanding contribution to surgery and medical education. Indian Association of Pediatric Surgeons, Odisha Chapter, felicitates Professor Niranjan Parida, a true luminary in pediatric surgery.
Next, I would like to call upon stage Colonel Dr. Rabindra Kumar Bal.
Colonel Dr. Rabindra Kumar Bal is a renowned pediatric surgeon and a medical scholar who has dedicated more than 40 years to improving pediatric surgery, clinical education, and research at the top medical schools of the country and in the armed forces. His exceptional contribution to pediatric surgery has remarkable career in clinical leadership, medical education, and research. He has established standards of clinical excellence, intellectual rigor in Armed Forces Medical Corps Pune, PGIMR Chandigarh, and prestigious army hospitals. As the head of the Department of Pediatric Surgery, he has demonstrated visionary leadership and fostering a culture of academic rigor, teamwork, and innovation. His guidance as a mentor and postgraduate dissertation supervisor has shaped many accomplished surgeons who continue to uphold his legacy. A prolific contributor to medical literature, Dr. Ball has authored and presented numerous papers in national and international flora. Colonel Ball gets honored by the Indian Association of Pediatric Surgeons, Odisha chapter, for his outstanding service and unwavering dedication to pediatric surgical excellence.
Next, I would like to call Professor Dr. Pravas Chandra Subudhi.
Professor Dr. Prabha Chandra Subudhi, an eminent pediatric surgeon, teacher, and mentor whose career exemplifies excellence, dedication, and compassion in surgical care. Dr. Subudhi completed his MBBS from SCU Medical College, Cuttack in 1976 and MS in General Surgery from MKCG Medical College, Barampur in 1980. He went on to earn his MNMS in General Surgery in 1981, followed by his MCH in Pediatric Surgery from the prestigious Christian Medical College, Vellore in 1985 and DNB in Pediatric Surgery from the National Board of Examination, New Delhi in 1986. In 1999, he received the esteemed clinical fellowship in neonatal surgery from the Institute of Child Health and Great Ormond Street Hospital of Children, London, one of his world's foremost pediatric institutions. His academic journey spans several decades, beginning as a junior lecturer at Vellore, then MKCG Medical College, later rising through the ranks to serve as the professor of pediatric surgery at SVP PGI Institute of SCV Medical College, and retired in 2012 after a distinguished career dedicated to teaching and clinical excellence. Professor Subudhi has contributed significantly to medical research. In recognition of his outstanding contributions to healthcare, he was honored with the Bharatiya Chikitsa Sanman Puraskar in 2003 and Rajiv Gandhi Sadbhavana Award in 2011. A teacher par excellence, a visionary surgeon, and a compassionate healer, Professor Subudhi, a name that is synonymous with quality, sensitivity, and enduring service to pediatric surgery, is honored by the Indian Association of Pediatric Surgeons, Odisha chapter.
Dr. Ram Narayan Das, come on
It
stage.
is with profound respect and admiration that we honor Dr. Ram Narayan Das, a trailblazing and empathetic pediatric surgeon. His unwavering dedication, humility, and lifelong commitment to the field of pediatric surgery has served as an inspiration to countless generations. An esteemed graduate from MKCG Medical College and subsequently a postdoc from the prestigious Banaras Hindu University, Dr. Das has exemplified excellence during his tenure at SBP PGIP Cuttack and subsequently at MKCG Medical College Barampur, where he has profoundly influenced the development of numerous surgeons through his expertise, empathy, and path. Through the execution of intricate reconstruction, including pull-throughs for anorectal malformations and disease, repairing cloaca and bladder anomalies, esophageal atresia, diaphragmatic hernia, and cleft lip and palate, frequently in challenging circumstances, he embodied the essence of determination and dedication that characterizes genuine clinical excellence. His groundbreaking contributions to gastric teratoma and development of gastric pull-off surgeries stand as significant achievements in the realms of surgical bravery and creativity. A surgeon who eschews recognition, Dr. Das' legacy is found not in accolades, but in the lives he has influenced, the trainees he has guided, and the numerous children he restored to health. His statement, "My satisfaction comes from being recognized as a pediatric surgeon amidst stalwarts," reveals a profound sense of his humility and unwavering commitment to his field. It is with great pride and deep gratitude that this is presented by the Indian Association of Pediatric Surgeons Odisha chapters on behalf of the esteemed community of pediatric surgeons.
I would like to call upon stage Dr. Vikas B Tripathy to deliver vote of thanks.
Quick announcement. Our second edition of IAPS textbook now available. All of you, those who are interested, there is a special discount of 30%. So, order your book from there and have a glimpse of the. Thank you.
Respected seniors, dear colleagues, and my young friends, Namaskar. Standing here today fills my heart with emotion, a beautiful mix of pride, gratitude, and nostalgia. Completing my tenure as Secretary and Treasurer of the Odisha chapter of IAPS 24-25 feels like coming to the end of a memorable chapter, one that has given me far more than I could ever give back. These 2 years have been a journey of togetherness, of tireless days, joyful teamwork, and countless moments of learning. We faced challenges, yes, but each time the support and goodwill of this family lifted us higher. Organizing the National Conference of IAPS in our own Odisha was not just an event, it was a dream come true, a collective dream that we turned into reality with faith, dedication, and the blessings of Lord Jagannath. Alongside, we held many academic meetings where every discussion, every gathering strengthened the fabric of our fraternity. What has touched me most deeply, though, is the way our chapter has embraced the young generation. We have tried in our small ways to open doors to our residents and junior faculty to help them make their rightful place to the national platform. Seeing their faces shine with confidence, that for me was the greatest reward. We also reached beyond our walls to create awareness about pediatric surgery among other medical professionals and among the public so that more children can be helped and more lives can be touched. To my respected seniors, your blessings and quiet guidance were my consistent strength. To my colleagues, your friendship and faith made every task lighter. And to our residents, your energy, your sincerity, your spirit kept all us inspired. As I will pass on this responsibility soon, I do so with a heart full of gratitude and immense pride, whatever we have built together. The Odisha chapter today stands stronger, more united, and more visible in the national forum than even before. And that is because all of you. Thank you for giving me this once in a lifetime opportunity to serve. Thank you for walking besides me through every challenges, every success, every moment that becomes a memory. May the spirit of pediatric surgery in Odisha continue to grow, to shine, and to serve every child in need. Jai Jagannath. We'll break for a short coffee break, then we'll assemble for the next.